So thank you for tuning into the channel. As the video states, I'm going to be going over the New England Journal of Medicine article referring to the differences between Ticagrelor and Clopidogrel. Ticagrelor is called Wallentin and Clopidogrel is called Plavix. And for those of you that want to just get the answer to the video, I can say it right now, and then I'm going to go into the graphs and kind of what the differences were about the two drugs. So bottom line, Ticagrelor was shown to be superior than Clopidogrel in patients who had acute coronary syndromes who were monitored for primary events regarding death, referring to like vascular or MI or stroke. So now that's kind of done. Now I want to go back into the paper and kind of explain what that all meant. These are two drugs that work by disabling the ability for platelets to form clots. And they do this by binding to a specific receptor on the platelets called P2Y12. And this P2Y12 pathway kind of works kind of like this. I'll put up a graph. And it, bottom line is it puts GP2B3A onto the surface of platelets. And this then is able to then bind to other platelets through fibrinogen, allowing for this platelet sheet to form. So if you're able to stop this P2Y12 from being activated, then you're going to decrease the ability for platelets to form platelet sheets. And that's the theory behind these two drugs, Clopidogrel and Ticagrelor. Now, when I was pimped on the floor, I was asked what the difference between the two drugs is. And immediately off the bat, I was like, oh, Ticagrelor is reversible and Clopidogrel is not reversible, which is 100% correct, but is not one of the main things that the attending was wanting me to say. So yes, that is completely true. Good job for Chris remembering that from Sketchy. The other thing that you have to know is that one of them is a prodrug and the other one is not. So Clopidogrel is a prodrug. And this is from a category called thienopyridines. And this classification means that they have to go through the liver and CYPs activate them. So cytochrome P450 oxidases activate Clopidogrel to become an active drug, which then can now actively bind to P2Y12 receptors on platelets. And the CYPs that are mostly used in this process in vivo studies have shown to be CYP3A4, but 2C9 and A12 have also been indicated as components for this, kind of out of the scope of this paper. But moving forward, you have this drug, that's how it binds, and that's how it actually works in the effectiveness for this paper. So what did the Plato trial study? And this was what the Plato trial was referring to. It wanted to look at people who came in with acute coronary syndromes. Acute coronary syndromes are a group of diseases that are focusing on atherosclerotic events that cause decreased perfusion of the heart. They are usually defined as unstable angina, STEMIs, or NSTEMIs. Like this is per step up or anything that you want. And so patients that came in with this diagnosis, so like either risk factors or they had ST elevation or ST changes on EKG or activated lab values, kind of like troponins were increased. So with these situations, they took this group of people, around 18,000 individuals from like, I don't know, 800 plus institutions, and they randomized what drugs they were going to provide them in order to prevent cardiovascular events from happening in the future. So they came with a disease. How are they going to prevent it? Well, the two options they were going to give them were Clopidogrel and Ticagrelor. So after giving these two drugs randomly, there was like some caveats to this, but pretty much it was randomized. And here's the data that you want to look at to ensure that there was a randomization between the Clopidogrel and the Ticagrelor study. So this shows us that, I mean, the mean, the sex, what other things were there? Body weight, BMI, the race, CV risk, like other medical histories, they're like pretty similar. Like look at history of dyspnea, 15.1% in Ticagrelor and 14.6% in Clopidogrel. Kind of interesting, actually, I'll get to that later. But all of them were very much similar. So the results from the drugs would then be indicated on the drug itself, not because of the population it was being provided to randomly. So what they looked at was they wanted to understand the value of these drugs in reference to primary endpoints. And what I said in the very beginning of the video was there were two primary endpoints that they wanted to look at. The first one was the death from vascular causes like MIs or strokes. They wanted to look at that. And the second thing they wanted to look at was bleeding issues. So was there more bleeding caused by either of the drugs? So the reason why they wanted to look at the vascular causes was because if this drug is more efficacious, then this drug should be provided more than the clopidogrel. So we looked at this, and this is what the graph shows. This is figure 1 of the paper. And if you're looking at the paper, looking at the figure with me, you're able to see that in the top right of the corner, they are able to stratify clopidogrel and ticagrelor. And the reason why the clopidogrel line is higher is because that line is referring to the number of primary endpoints reached. So it accumulates as the months occur. So the x-axis is time in months. And we see here that more primary events are reached with clopidogrel, suggesting that, or it shows that a p-value of 0.001 or less than that ticagrelor had less of these vascular causes of MIs or strokes within this 12-month time period. So this tells us that ticagrelor is superior in that, and the p-value shows that there was no, that it was a statistically significant difference. The other thing they wanted to look at was the bleeding disorder. And this is because ticagrelor, being that it is a more potent inhibitor of P2Y12, it was suggested that this would potentially have more effects on more bleeding disorders. But clopidogrel is not as effective comparatively. And we did show that while the line is lower for clopidogrel for that primary event of bleeding disorders, so major bleeding outcomes, we found that clopidogrel was less, but the p-value for this was 0.43, which means that it was not a statistically significant finding. So what we show here is that in this Plato study, it was determined that ticagrelor is superior to clopidogrel for patients who have ACS in their ability to reduce vascular events such as strokes or MIs within the 12-month time frame that the paper is showing. There should be more data, I think, out that shows longevity beyond the 12 months, but this paper capped it off at 12 months. And this was done in like 2006, 2009. So whatever you were doing back then, I was graduating high school. This study was going across the entire nation, North America. So for all my viewers out there, other places, that was not so. Some other things that I do want to mention, though, are two things. So in the ticagrelor study, or this ticagrelor, there was actually some adverse outcomes. One of them was this random intracranial bleeding, which is a rare occurrence, was statistically more significant in the ticagrelor study compared to the clopidogrel. And the other thing that was more common was dyspnea. So dyspnea was one of the things that occurred more frequently in people who were ticagrelor compared to clopidogrel. And most episodes last less than a week. Discontinuation of the study drug because of dyspnea occurred in 0.9% of patients in ticagrelor group. So almost 1% of the patients had to stop their ticagrelor because of the dyspnea that they had. So it's actually a pretty, fairly significant amount, which I thought was kind of interesting. So the next thing that I do want to talk about, which is something that our school really hounded into us, was regarding disclosures. So this paper was referring to ticagrelor and clopidogrel, so Wallentin and Plavix. So kind of outside the scope of this, and might be not even that important, but I did want to just bring it up because I think it's interesting, is so Plavix is actually a drug that anyone can make right now. So it's been out for a while now, so really any generic works for Plavix. But Wallentin, made by ticagrelor, is not. It's actually made by a specific company, and the specific company is AstraZeneca. And this paper was supported by AstraZeneca, so that raises a slight red flag. So when we look at this, when you look at papers, the authorships, you want to look at the first author, which is the main author, is big deal stuff. Last author is pretty big deal, and everyone else in between. So not only the fact that the paper was supported by AstraZeneca, which kind of makes sense because the paper shows that this AstraZeneca drug was superior than this generic drug. Cool. We do know that the first author, Dr. Wallentin, was receiving consulting fees from AstraZeneca, as well as grant support from AstraZeneca. And like throughout the paper, like I didn't highlight all of them, but many other people that were in this study also had support from AstraZeneca, which I find interesting. So that was like the main thing I want to get about this paper. And I also wanted to talk about just a little bit more. So this paper had a very specific group. You cannot use this stuff to say that ticagrelor is superior in other aspects where you would use this drug. This is kind of exemplified by another paper kind of focusing on this thing, the Euclid Study. So the Euclid Study was looking at peripheral vascular disease, specifically in stable patients. And for the treatment of peripheral vascular disease or peripheral artery disease is actually what the paper was referring to. And this is like if you have like ankle brachii index less than or equal to 0.9, you have 2 to 4 times increase of cardiovascular like mortality. So the treatment for this like Ph.D, like as we know, like if you get an UWorld question, you're gonna be like, okay, I want a graded exercise program, sick. The other thing you want to give them is aspirin, sick. The other thing you're going to give him is like cilostazol, like he lost the ball, like this is the sketchy thing. Those all work for symptomatic, or cilostazol is like a symptomatic treatment. And these are actually A-graded data. So that's actually like backed up by like a lot of data that is like very convincing. Now there's a B-level data that says that you should actually be using aspirin, ASA, or clopidogrel. So there was another paper, this Euclid study, wanted to look at, okay, so in the setting of people that have Ph.D, stable patients, are there any differences in benefits for people who get ticagrelor versus clopidogrel? And what they found out was that they were completely equal in this study, but they also further confirmed so Brilinta and the Plavix were completely equal in regards to Ph.D outcomes for these patients. But what this paper did also show was that people who were taking Brilinta had more stops secondary to dyspnea as well as bleeds compared to the clopidogrel. So it's completely different, but it does show that there is a persistence about this fact that ticagrelor can have an increased risk of causing dyspnea in patients, leading to discontinuation of medicine. But it also is important for us to understand that this doesn't mean that ticagrelor is superior for all things, but specifically in the setting of people who have ACS and for the prevention of vascular mortalities. So that was pretty much the paper that I want to go into. I hope you guys enjoyed it. It's been a while since I've made a video like this, but it was a paper that I got pimped on my floors during my cardio week. I'm going to be making another paper pretty soon about some more news that's come out about ticagrelor in the recent month. So I hope you enjoyed this video and like and subscribe. Thanks.